Good evening, dear doctors. So after a long time, I'm posting a video again in YouTube. I hope it will help everyone who wants to learn something in pediatrics. So today my plan is to discuss some of the OSCE questions, because OSCE questions, are the standard part of the examination everywhere these days. So let me discuss about some of the OSCEs from pediatrics, especially focusing on neonatology and respiratory system. Okay, so I hope it will really help you. So let's proceed further. So look at here. The first question is, if the OSCE question is asked like that, okay, they have shown you a picture and the CT scan. So what is the diagnosis they are asking, and they may provide you a clinical clue here, and the clinical clue is, this is a newborn baby, okay, a newborn baby who is getting blue or getting cyanosed when the baby is quiet, when the baby is at quiet state, okay, or not crying. But when the baby is crying, there will be no cyanosis, the baby is getting pink. And another thing is, when the baby is breastfeeding, because of hypoxia, the baby is getting slightly bluish. So what is the diagnosis? So if that type of clinical clue is provided to you, okay, think about choanal atresia. Choanal atresia. Now what is this choana and what is atresia? I'm sure every student know. Just look at the picture first. This is the nasal cavity, okay, nasal cavity, and here is the nasopharynx. Now in this case, look at this is normal one, okay, but when I compare this first picture with the second one, here is a blockage. The nasal airway is blocked. Then that means there is a bony septum which is blocking the continuation of the nasal cavity with nasopharynx. So this is called choanal atresia. Atresia means it is not formed, it is not open, it is still blocked. So this is the diagnosis, choanal atresia. And clinical presentation we have already talked about. Now look at the CT scan finding here. This is the nasal cavity and here is the nasopharynx. So exactly at this area you can see there is a blockage, okay. So this is called choanal atresia. Now what is the treatment? The treatment is not asked here, but still we want to know about the treatment as well. The treatment is surgery, okay. You need to remove this septum which is blocking the nasal airway, so that the continuation is maintained. Let's go to the other case. Now question number 2, look at here. This is an infant, okay, who presents with stridor. Stridor means high pitch, harsh type of inspiratory sound. It can be expiratory, but inspiratory sound is much more common than expiratory in case of stridor, okay. And stridor occurs if the upper airway, relatively larger airways, are blocked, like larynx, trachea, and even the pharynx. Along with this stridor, here is also given omega-shaped epiglottis as the clue. And you can see, look at the picture here. This is an omega-shaped epiglottis. So if they ask you what is the diagnosis by providing these two type of clue, the diagnosis is very straightforward. It is a case of laryngomalacia. Laryngomalacia. Okay. Laryngomalacia is a congenital disorder of the larynx where the epiglottis, okay, this is epiglottis. The epiglottis is, it is a very soft, okay, it is very soft. So that is the main problem here. And this soft epiglottis, when the baby is breathing, it will, block the airway. So as a result of that, there will be stridor in the baby, okay. So treatment is surgery again, okay, surgery, and differential diagnosis of the stridor, okay. I like to highlight it. The differential diagnosis of stridor, very important question, dear students. So please, pay attention. First is acute laryngotracheobronchitis. Laryngotracheobronchitis, which we call as a Croup syndrome. Okay, Croup or Croup syndrome. Second one is acute epiglottitis. Acute epiglottitis. And the third one is called foreign body obstruction. Foreign body obstruction. And another one also we can highlight. This is called acute tracheitis. Acute tracheitis. These are more common than the other. There are so many others which can cause stridor, but in the pediatric practice, these are more common than the other. Now, a little bit of knowledge regarding each of them. Acute Croup syndrome is mainly caused by viruses, and the most common virus which cause Croup is para-influenza virus. Para-influenza virus. This is a very important question. Okay. Now, this Croup syndrome is characterized by barking cough. Barking cough. And when you take the X-ray, the X-ray of the neck, then you will see steeple sign. Steeple sign. Steeple sign means narrowing at the area of cricoid cartilage. Okay, so these are very important point. Now, regarding the acute epiglottitis, it is a bacterial infection. It is mainly caused by bacterial infection, and the common bacteria which cause this are Haemophilus influenza type B and pneumococci. Pneumococci and group A beta hemolytic streptococci. Okay, so these are the bacteria which can commonly cause acute epiglottitis. Now remember, the presentation of acute epiglottitis would be, there is a high grade fever. Okay, high grade fever. There will be stridor. That's why we are talking it as a differential diagnosis here. And because of this, involvement of the epiglottis, there will be severe difficulty in swallowing. So the baby cannot even swallow the saliva. So there will be drooling of the saliva from the corner of the mouth. And the typical position is maintained by the child, and that is called tripod position. Tripod position. So these are some of the very important points regarding acute epiglottitis, which will give you a diagnosis. Then, if you do the X-ray, the X-ray will show thumb sign. Okay, X-ray of the neck lateral view will show you thumb sign. Please memorize it. Steeple sign in case of Croup and thumb sign in case of epiglottitis. Okay. Now, regarding the foreign body obstruction, now this is a very typical history which is provided to you, and that history is all about, sudden onset of severe cough and difficulty in breathing. Sudden onset. The child was probably playing with something, and suddenly, the child started to cough with difficulty in breathing. This is the clue for foreign body obstruction. So it is sudden onset. Sudden onset. Okay. Breathlessness as well as cough. And of course, there will be stridor. And acute tracheitis is a relatively rare condition than other three, but there is a fever. Again, it is mainly caused by bacteria like Staphylococcus aureus. There is fever, and there is something known as brassy cough. Okay, so this much information will be enough from the stridor. Okay, let's move further. Question number 3. Now see there. This is the very common, X-ray which is asked in the exam, and the clinical clue is also provided to you. This is an infant which presents with fever and barking cough. Just now we discussed about this, so you will have very good time or easy time to diagnose it now. And stridor is also there for 1 to 2 days. So whenever you see a barking cough and this type of X-ray which is showing steeple sign, this is called steeple sign. The diagnosis is, of course, Croup syndrome. Okay, this is called Croup syndrome or Croup. And name the sign which is shown in the X-ray. This is steeple sign. Now I want to ask you one more question. What is the most common causative organism which is causing Croup? The answer is para-influenza virus. Okay, para-influenza virus. Other respiratory viruses can also cause it. Now let's move further. Question number 4. Again, the same discussion which we are doing has come back here. Name the sign which is shown in the X-ray. So this is the X-ray of the neck, okay, lateral view. X-ray of the neck, lateral view, and you can focus here in this area, you know. So this is called thumb sign. This is called thumb sign. Now, you know it, if thumb sign is shown in the X-ray and some clinical clue is provided, or even without clue, you know, this much information is good enough for us. So this is a case of acute epiglottitis. Acute epiglottitis. So they may ask you some important question from epiglottitis, which I just discussed with you. And here they have asked what is the clinical feature of this condition. So you can say high-grade fever, very short history, difficulty in swallowing, difficulty in breathing, drooling of the saliva, dry port sign. So a lot of things are there. Okay. And one more information I like to share with you here. When you are examining a child with acute epiglottitis, okay, don't examine the child without, resuscitation measures in front of you, because while you examine, suddenly the airway may undergo into spasm and we may lose the child. There may be death of the child if resuscitation equipments are not ready. Okay, so if you are not familiar with the resuscitation equipments, then better you should call your senior there, maybe anesthesiologist, maybe a senior pediatrician, whoever, and then examine the child nicely. Okay, let us move further. Now, question number 5, dear students, dear doctors, see this. This is one way of asking the OSCE question. So see that this is the age group of the child, 0 to 2 months, 2 to 12 months, and 1 to 5 years. And they may ask you what is the normal respiratory rate. So this is a very good way to remember here. From 0 to 2 months, the respiratory rate, is less than 60 per minute. Okay, 2 to 2 months, it should be less than 50 per minute, and 1 to 5 years, it should be more than 40 per minute. And after that, okay, when the baby or the child is more than 5 years, okay, it should be less than 30 per minute, and it gradually, okay, decreasing according to the age and ultimately become the adult range. Okay, so this is a very, very common question which is asked in the exam. Now, what are the signs of the respiratory distress? Now, this is another question which is commonly asked to you. Now, let's quickly talk about it. Signs of respiratory distress. So, what is respiratory distress first? Respiratory distress means the child is breathing with a lot of difficulty. The breathing is not easy for the child. So, we can see some of the signs in the child so that we can say, yes, this child is breathing with a lot of difficulty. So, what are those? Number 1 is indrawing of the chest indrawing. If a child is breathing with chest indrawing, that means the child is breathing with a lot of problem. Number 2, sternocleidomastoid and trapezius. These are called accessory muscles of the respiration. They are in use. Okay, it can be seen in a little bigger child and definitely in case of adults. Number 3, okay, what are the other signs now? Nasal flaring. This is because of the contraction of Eli-Negi muscle. Okay, contraction of the Eli-Negi muscle. This is a little bit extra information for you. Number 4, in a very small baby, especially in preterm babies, there may be head nodding as well. And another one may be cyanosis or bluish discoloration. But remember, some of the pediatrician, okay, says it is a feature of respiratory failure rather than respiratory distress. But we can include it in a respiratory distress, and later on you can say it may be going into respiratory failure. Okay, so these are the signs of respiratory distress. Now I like to highlight one point before I move to the other case, and that is if a child is breathing very fast and having the signs of respiratory distress, that means there is some serious respiratory disease in the child. Okay, so probably this child needs to be admitted in the hospital with oxygen and immediate treatment. Now let's move on. So another case is here. Just see here now. So they may provide you this type of picture and ask you some questions here. Now on A, what is shown here? the inspiration is longer than the expiration. There is no gap. See there is no gap, and expiration is almost 2/3 of the inspiration. So identify the breath sound. If they ask the question like this, the answer is very simple. It is called normal vesicular breath sound. Okay, this is normal vesicular breath sound. Now another one, and see here inspiration, okay, is shorter than the expiration. Means expiration is longer than the inspiration, and there is still no gap. There is no gap. So this is called vesicular breath sound with prolonged expiration. Prolonged expiration. So this prolonged expiration is seen in this condition where, okay, the smaller airway are narrow, okay, like bronchiolitis, bronchial asthma, okay. In case of adult, COPD. In children, we don't talk about COPD, but there are some chronic lung diseases, okay, which may act like COPD, but the term is not usually used in case of children. So the lower type B is, you can say, bronchiolitis, and bronchial asthma. These are the common condition in the child. Okay, let's go to the other case now. Number 7. The similar type of case. Okay, see here the picture is provided to you. Again, a type of breath sound, but here the inspiration and expiration are equal. Okay, means inspiration is equal to expiration, and there is a gap. There is a gap between them. So this is called bronchial breath sound. Bronchial breath sound. Now bronchial breath sound is not normal. Okay, it is abnormal. And how to identify this bronchial breath sound in a child or in a patient? Okay, there is a way. So you put your stethoscope over the trachea, on the neck over the trachea, and what type of sound you can hear. Okay, the same type of sound if you hear over the chest in the abnormal area, that is called bronchial breath sound. Okay, so in which condition it is found? This is the second question. So you can remember consolidation or pneumonia is one of the very common condition where bronchial breath sound is heard, and in this case it is called tubular type of bronchial breath sound. Tubular bronchial breath sound. Okay, another condition where bronchial breath sound is heard, okay, is collapse, where the bronchus is patent bronchus. This is also important to memorize. Patent means the bronchus is not blocked completely. Okay. The third one, at the top surface of pleural effusion. Okay, at the upper surface or upper level. So this is another, cause or type of bronchial breath sound, and we call that amphoric type of bronchial breath sound. Okay. So these are, or you can also say, different other terms are there, like egophony is there, different terms are there regarding this. Okay, we'll talk it later, but this much information will be enough for this type of question. Now let's move on. Another one is a very typical case. They may provide you this type of x-ray, the chest x-ray, and straightforward ask you the diagnosis. Now see here, this is a right lung and this is a left lung. Okay, so the right lung is classically having, a homogeneous white opacity here. Okay, homogeneous white opacity in the middle lobe, of the right lung. So this is upper lobe. Okay, this is middle lobe, and this is lower lobe of the right lung. So this is called lobar pneumonia. Okay, lobar pneumonia, because one whole lobe is consolidated. So you can say lobar pneumonia of the right middle lobe. So that is a proper diagnosis. And what are the auscultation finding they have asked? So the auscultation finding will be bronchial breath sound. Okay, bronchial breath sound. And which type of bronchial breath sound? I just now talked about this. This is called tubular type of bronchial breath sound. And especially there are 4 stages of the lobar pneumonia. A little bit of revision for you. The first stage is called what? Stage of congestion. Second stage and third stage are called red hepatization and gray hepatization, and the last stage is called stage of resolution. So in case of first and last stage, that is stage of congestion and stage of resolution, you hear crackles, okay? And in the stage 2 and 3, that is red and gray hepatization, you hear bronchial breath sound, okay? So this is the important point. Now, name 2 bacteria which cause this. Absolutely easy question. You can write pneumococci, and Klebsiella. Okay, these are quite common. You can also add group A beta hemolytic streptococci, Haemophilus influenza, like that later on. But they rather cause bronchopneumonia than the Lobar. Now, another interesting question in case of pediatrics. Now, look at this question here. You are assessing the 1-minute Apgar score of a newborn baby. Apgar score. Okay. On assessment, you note the following about your newborn patient. Heart rate is 101, means I will give score of 2 if heart rate is more than 100. Cyanotic body and extremity. Now here, if the whole body is blue, cyanotic body and extremity means the central part is also blue, peripheral part is also blue, right? I'll give a score of 0. No response to stimulation means grimace. There is no response, so 0. No flexion of extremity, 0. And strong cry is 2. Now, actually speaking, this is a hypothetical case. The baby may not present like this, okay? I mean, there is a whole body cyanosed, okay? There is no respiration, response to stimulation, but the baby is crying. And this, usually doesn't happen. But we can ask this type of questions, to make you, a bit to do a proper exercise regarding the Apgar score. Fine. So the total score is 4. So A is the correct answer here. This type of questions are very commonly asked in OSCE exam or even during the MCQ. So please prepare well. Now, another is a newborn again. They have shown you a picture here. Look at the size of the newborn. It is big. Okay. So this looks like a big baby, also known as large for gestational age baby. Okay. Now the question they have asked is, what are the causes of large for gestational age baby? Okay, so you can easily answer. Number 1 is infant of diabetic mother. Okay, infant of diabetic mother, especially gestational diabetes, they have big baby. Number 2, okay, number 2, is, what are the other causes? The other causes, sometimes it may be a genetic cause, or some other disorders. Like, I can give you an example here. Okay, there is a clue which is provided to you later in other OSCE exam. The baby will have repeated hypoglycemia. Okay, and the baby is very big. Okay, all the organs are bigger, and that is called Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome. Okay, so this may be another cause of big baby. And third, sometimes even post-term baby, they become big. Okay, post-term baby, they become big. So these are some of the causes you can always write here. Mention the 3 complications of infant of diabetic mother. Now, this case, if you pay attention, very carefully, this baby is having, okay, see here, plethoric face. Now, plethoric face means it is a case of polycythemia. Okay, polycythemia is very common in infant of diabetic mother, and this baby is classically having hairy pinna also, which is not shown here in the picture. This hairy pinna is considered as a pathognomonic feature of infant of diabetic mother. Now you can easily write the 3 complications of the infant of diabetic mother. I want to show you in the next slide here. The 3 complications would be 1, hypoglycemia, very important complication, hypocalcemia, which is very common also, and congenital malformation. Okay, these congenital malformations are so many. Like congenital heart disease are also quite common in a infant of diabetic mother. Neural tube defect are also common. Okay, like spina bifida and even anencephaly. Then some other are, we call it, lumbosacral agenesis or caudal regression syndrome, caudal regression syndrome, or even microcolon. These are some of the common congenital malformation. Some of the questions which are very commonly asked from here, in your upcoming future exam are regarding the congenital heart disease. Okay, TGA, transposition of great artery, and another one is hypertrophic obstructive cardiomyopathy. These are quite specific complication in case of heart disease in infant of diabetic mother. Okay, another is VSD. So these are quite important question. So please prepare it well. Let's move on. Another question which may be provided to you is like this type of picture, and they simply can ask you the diagnosis. So look at this. This baby looks very yellow. Okay, so this is a case of jaundice. Okay, so this is neonatal jaundice, also known as neonatal hyperbilirubinemia. Okay, so write 4 causes for this condition. Absolutely easy. I will not forget about physiological. Okay, physiological jaundice, which is the most common type of neonatal jaundice. Second one are pathological. Some of the pathological jaundice would be jaundice because of RH incompatibility. Okay, another one. The another one is some other hemolytic anemias like G6PD deficiency, hereditary spherocytosis, and another may be hypothyroidism. There are so many others, I can give you a long list here, like Crigler-Najjar syndrome, okay, even Gilbert syndrome, even breast milk jaundice, okay. Then because of some problem in the GI tract, some obstruction, so many are there, but you can write any 4. Now, write the treatment. If it is a physiological jaundice, you don't need any treatment here, but once a pathological jaundice is there, then we should give a treatment like phototherapy or exchange transfusion. We can call it double volume exchange transfusion. Okay, so see this, phototherapy and double volume exchange transfusion. Okay, and sometimes we can take the help of some of the drugs also, especially if it is Crigler-Najjar syndrome type 2. Phenobarbital is commonly given. Another one, this type of questions can also be asked. They show you, this type of, instrument. We can say, a device or something like that. A setting, you can say. What is the name? So this is called radiant warmer. Radiant warmer, a radiation warmer, which is present in all the delivery room and where the, we should take care of the newborn. Okay, and write 2 uses of it. So what are the 2 uses? Easily you can use taking care of the newborn. Care of the newborn means right after the time of birth, we accept that newborn, or we handle that newborn, and we examine the newborn in this area. Okay, so there is a source of the light here, there is a source of the heat, everything is here. It is very easy for us to examine. And number 2, for the resuscitation. For the resuscitation of the newborn, if it is necessary, this is the ideal place where we do the resuscitation. Okay, so these are some of the questions you get from the radiation warmer. So number 13, we can answer. So identify the instrument. So every student can answer it quite confidently. This is called ambu bag or bag and mask. Okay, bag and mask apparatus or ambu bag or bag and mask. Okay, ventilation, you can say. What are the indications for using it? So this is a favorite question. The indications for using bag and mask ventilation are indications for bag and mask ventilation. Favorite question, okay? They are number 1, when the heart rate of the newborn is less than 100 per minute. This is an important question. Less than 100, okay? Number 2, when there is cyanosis. the baby is completely blue all over. Cyanosis all over. Number 3. Okay, what else? When the baby is not breathing. When the baby is not breathing. Not breathing means either gasping, okay, or no breathing at all. No breathing at all. Both may be the condition for bag and mask ventilation. Okay, so these are the most important 3 indications for bag and mask ventilation. Don't forget that, okay? Favorite question. Now write one contraindication of this. Now, you can always answer this. Whenever there is diaphragmatic hernia, okay? Diaphragmatic hernia, or you can say congenital diaphragmatic hernia. Okay, you don't use bag and mask ventilation. The bag and mask ventilation, bag and mask is contraindicated. Contraindicated. Okay, so this is a very important point. So then what we do then? What is the alternative? We don't go for bag and mask ventilation. Rather, we do endotracheal intubation, and then you go for ventilation. Means all the air will go into the lung and the baby will improve. Why bag and mask is contraindicated? Because when bag and mask ventilation is done, a lot of the air will go to the GI tract. In this case, the GI tract, mainly the stomach and intestine, are present in the thoracic cavity. There will be distension of the stomach, okay, and that stomach distension will further compress the lung, so the baby will not improve. That's why endotracheal intubation and ventilation is done. It's a very, very important question. Now, this is another question which is commonly asked. What is the dose of IV adrenaline in term infant during neonatal resuscitation? So the answer is C. See this here? This is the answer, okay? 0.1 to 0.3 ml per kg in 1 to 10,000 dilution. Many of the students, they confuse with this 1 to 1,000. Okay, so please see the question carefully. You have to read the question twice before you answer this, okay? So C is the correct answer. So it is 0.1 to 0.3 ml per kg in 1 to 10,000 dilution. This is important one. Now the students, so how to give it? It is given especially through the umbilical vein or through any other veins, but umbilical vein is right there at the time of birth, so we can use it, umbilical vein, okay? And we can repeat it every 3 to 5 minutes. 3 to 5 minutes. We can repeat it up to 2 to 3 times, okay? And along with this, you continue bag and mask ventilation or endotracheal intubation and ventilation, and you can also go for chest compression till the baby improves. So this is the dose of IV adrenaline. Now one more question which may be asked, in some other types of OSCE exam is, if you give adrenaline through endotracheal tube, okay, adrenaline through endotracheal tube, what is the dose? That is 1 ml per kg of 1 to 10,000 dilution. Okay, so don't forget that because it may be asked. Now another is a X-ray from the respiratory system. So this X-ray of a child which is showing pneumatococcus. What is the most likely diagnosis? And write one complication. Whenever you hear the term pneumatococcus, okay, they are talking about Staphylococcal pneumonia. Staphylococcal pneumonia, and these are the pneumatococcus which are shown here. What is the most likely diagnosis? Staphylococcal pneumonia. Write one complication. It may rupture and lead to pneumothorax, or it may turn into lung abscess. So these are some of the important complications. Okay. Another one is, look at this X-ray. This is a newborn baby which is delivered at 32 weeks of gestation, and X-rays are shown here. So whenever you see a 32 weeks gestation baby, this is a premature baby, premature baby, okay? So what is the diagnosis? Look at this. This lung, is showing one particular finding. This is showing air bronchogram, and it is showing white out lung. Okay, so these two are showing this is called hyaline membrane disease or respiratory distress syndrome of prematurity. This is an important point. Okay, right. The treatment, there are so many different types of treatment we can say here. Number one, in the beginning you can do CPAP with oxygen. If still the saturation is less than 92%, we can go with surfactant therapy, and still if the oxygen saturation is less than 92%, we can go with ventilator. So these are the different types of treatment you can highlight here. Another, okay, look at this X-ray, and the typical X-ray, you may not need any clue here, because this X-ray is showing the intestine or the GI tract or stomach is present in the thoracic cavity from the left side of the diaphragm. So this is a clear-cut case of congenital diaphragmatic hernia. Okay, they may give you a clue, a clinical clue, like at the time of the birth the baby is having scaphoid abdomen, okay, and bag and mask ventilation is not helping the baby. It will rather aggravating the situation, means the baby, rather than improving, the baby is deteriorating. That type of clue is provided. Okay, and how to resuscitate the baby, in the previous slide also we talked about it. Don't go for bag and mask, rather put an endotracheal tube and then connect with bag and then ventilate. Okay, that is the ideal way. Another one, see here, this every student or every doctor can identify this. This is called tracheo-esophageal fistula or esophageal atresia. Okay, and how to confirm the diagnosis? Very simple question. We pass red rubber catheter, or sometimes even NG tube can be passed, and now it doesn't go very downwards. Because of the obstruction, it will recoil and come back. Okay, and you can also take the X-ray, okay, which will confirm. What are the complications of this? One of the important complication is aspiration. Okay, aspiration, which leads to aspiration pneumonia. Okay, that is one of the major problem of this, and the treatment is of course surgery. Another question, okay, look at here, the clinical clue is provided. The percussion note is hyperresonant. So what is the diagnosis? They have asked like that. So here is the problem here, and whenever the hyperresonant term is there, it is a case of pneumothorax. Pneumothorax means there is presence of air in the pleural cavity. So what is the diagnosis? It is pneumothorax. What is the treatment? It is needle aspiration followed by tube thoracostomy. Okay, or you can say intercostal tube drainage, undersea water drainage. Okay, so these are the treatment here. Now question number 20, you can say this newborn is having purulent discharge from both eye. Okay, and this is a newborn baby. So this is a case of Ophthalmia neonatorum. And the treatment, the most common cause for this first is gonococci, one of the most common cause, okay, if not the most common, gonococci. Even chlamydia can cause this infection. So but gonococcus usually causes this type of purulent type of discharge. So if gonococci has caused the infection, then the treatment is ceftriaxone. Okay, IM, even one dose may be enough for the treatment here, ceftriaxone. Another one is a little bit about the bilirubin metabolism here. So they may ask which enzyme is involved here and in which condition this enzyme is absent. The answer is pretty simple. The enzyme which is involved in the conjugation of the bilirubin is called UDP glucuronyl transferase. UDP glucuronyl transferase. Okay, and in which condition this enzyme is absent? This is called Crigler-Najjar syndrome. Crigler-Najjar syndrome. Okay, Crigler-Najjar syndrome is of two types, type 1 and type 2. So in type 1 Crigler-Najjar syndrome, this enzyme is completely absent. It is absent. In type 2 Crigler-Najjar syndrome, it is decreased. And one very common question which is asked in neonatology exam is, phenobarbital can be used in type 2 Crigler-Najjar syndrome. Okay. Now another question which is very related with this, identify the treatment process here. This is called phototherapy. Okay, phototherapy. And you all know phototherapy is done for neonatal jaundice. And right to complications of this phototherapy, you can say dehydration. Okay, dehydration is one of the complications. And another complication is if the bilirubin, the type of bilirubin is a conjugated one, okay, it is called bronze baby syndrome. Bronze baby syndrome. Okay, and we don't do phototherapy when there is conjugated hyperbilirubinemia, but if it is done, then only bronze baby syndrome will develop. Now 23, identify this chart and write two causes of SGA babies. So this chart is called Lubchenco chart. Okay, Lubchenco chart, and write two causes of this SGA babies. Okay, of SGA babies. It is not showing SGA babies, but they may ask, two causes of LGA or something like that also, but they have asked SGA babies. So the two causes would be very easy for you, like any cases of hypertension in the mother, that is called pregnancy induced hypertension or PIH. Okay, and another is like if the mother is working too much, if she is a young primary gravida. Okay, if there is some serious disease in the mother, many things you can write. Any substance abuse in the mother, okay, substance abuse, all those things you can write. Okay, lots of causes are there. Now number 24, identify this sign. This looks like extremely premature baby. Okay, look at the face of this baby, extremely premature. Okay, this is called scarf sign. Scarf sign. What is the meaning of this? The elbow of this upper limb can cross the midline very easily in an extremely premature baby. Scarf sign. And write 4 problems of this premature baby. Number 1, hyaline membrane disease. Number 2, okay, you can choose one from each of the system, maybe very easy for you. Okay, from the cardiovascular system you can say PDA, patent ductus arteriosus. Number 3, from the GI tract you can say necrotizing enterocolitis. And number 4, from the central nervous system you can say intraventricular hemorrhage. You can write hypoglycemia, hypothermia, so many others. Okay, so this is a very easy question for you. Now number 25, what is that white sticky substance called? Okay, look at this newborn baby, they are showing this white sticky substance. So it is called vernix caseosa. Okay, vernix caseosa. What is the function of it? It is preventing the heat loss. Preventing heat loss from the baby. Okay, and which type of baby have it? Especially full-term baby and post-term baby. Full-term and post-term baby. Okay, usually preterm baby, they don't have it. Vernix caseosa. And remember, you don't need to forcefully remove it. It is actually protecting the baby. Now the last question for today. Okay, this is the ponderal index. So what is the ponderal index? Ponderal index is you have to choose the right option first. Ponderal index, how to know the ponderal index. The first one, okay, ponderal index. Okay, ponderal index is calculated to differentiate whether it is asymmetrical IUGR or symmetrical IUGR. In asymmetrical IUGR, okay, what is the value of the ponderal index? the Ponderal index is, okay, less than 2. Okay, less than 2 in case of asymmetrical IUGR, because brain is properly developed. Only the other parts of the body will be smaller here in case of asymmetrical IUGR. So that's why this is a important question here. Okay, and one more thing before I stop today's session is one question which may be asked here. In asymmetrical IUGR, why hypoglycemia is more common than preterm baby? Remember, it is always the thing called demand and supply. Demand is very high because brain is normal. In case of asymmetrical IUGR, it is demanding more glucose, but liver is shrunken, the storage form is less. As a result of that, the baby can quickly develop hypoglycemia. Okay, so dear doctors, let me stop here for today. Okay, and we'll continue this type of session again.